is our equipment. Oh, okay. Well, that's a lot. Good morning. Thank you guys for being here. Because really, there's no reason for the rest of us to be here if you aren't here. This is a unique conference in the world because this is, most conferences that people will go to are medical conferences, right? That are for medical professionals. This is oriented towards families, ideally, so that people can be apprised of what kinds of options might be available to them. Because we're talking about a extremely underserved community of people when we talk about pediatric patients with neurologic injuries. Basically a corner of medicine that was kind of like not really looked at for a really long time. And now all of a sudden we got a whole bunch of new things that come up that have promise. And that becomes a little bit overwhelming for a lot of people because there's too many options, and holy cow, some of them are really expensive. And you know, the question becomes, is that really worth the money you put into it? Sometimes it is, and sometimes it isn't. And the frustrating part of that is, how do you know? You might know somebody who went through a particular process. You might know somebody who's, done this therapy or that therapy, but that doesn't mean that your kid's going to respond to that in any way whatsoever. So sometimes you have to be able to engage a process and sort of figure out what is it that works for a particular individual. And that's really the point of this kind of a conference, is so that people get to know sort of what other options are out there. That becomes overwhelming also, right? Because, gosh, now you just know that there's more options. And there is a flow to these things that we see kind of come up where one way or another, people will find themselves, there might be some false starts one way or the other, but eventually we find our way into a path that seems to work for most people. And if the path you're on isn't working, well, let's change it up a little bit and figure some other things out. So essentially, our clinic, we've been in the place we're at since 1996. I started out mostly neurology of sports medicine, which meant that I was running concussion clinics for professional hockey players and professional football players, as well as non-professional college people and kids. Through that time, we had a large population of children on the autistic spectrum. The first residency program that I ever created was specifically for people that are treating people who are on the autistic spectrum. And my first resident. Since then, we kind of do a little bit more of an all-encompassing and comprehensive type of a residency for physicians who are interested in seeing primarily children with neurologic issues. These are medically complicated situations, right? I mean, you guys are living with a lot of these medically complicated situations, and that's a little daunting for a lot of physicians, and they're reluctant to go into that. And let's face it, at the end of the day, if you're, seeing 50-year-olds who are pretty neurotypical, that's maybe a different day than if you have a day full of kids who are definitely neurodivergent. We have 5 physicians in our office now. All of them were ultimately students of mine that had decided that they'd like to stick around and participate. So what are we talking about? We're talking about this thing right here. This is the most complex structure that we can conceive of because it is the thing that we use to conceive of things. And so it is the original quantum computer, and here's the thing about neurologic processes is when we remodel, and every day we remodel, we used to think that, there's a time in life where you don't remodel your nervous system anymore. Turns out they did a study a few years ago on some 80-year-olds in Minnesota, and they found that, hey, an 80-year-old remodels their brain just as much as a 25-year-old remodels their brain. It's just that they often don't do a whole lot of new things, so there's no real net change in that remodeling process. That's important. Children are going to continually remodel faster than we adults do. It's kind of their job is to keep remodeling. So that process is a flood of neurons come along. Those that get sensory feedback get to stick around, and those that don't get culled away for the next big flush. initially that flesh, these are little microtubule structures. They're little round structures that are just an assemblage of proteins. They're hollow, like a nerve will ultimately be. And an interesting thing about these little microtubules is it takes a little bit of current to consolidate them. Too much current, you just blow the thing up. You fry that nerve, basically. Not enough current, it's just not enough to get you over the edge that can actually stick around. As axons and dendrites attach to one another, the magic current is sensory input. So, what fixes people? Nothing fixes people. You're a living organism. The circumstances of your life are the circumstances of your life. Maybe you're an algae living in a pond, or you're a human living in Austin. The circumstances of your life will dictate who you become. The things that happen to you and the way that your nervous system operates that allow you to integrate information and be a participant in your community affect how the quality of those unions happen. We need sensory input because there is this reciprocal dynamic that what you did yesterday is what prepared you for tomorrow. What you did 3 months ago is what you're living now. And so you have to ask the question, how did I do? Well, how are you in your life? Is anything different? Are you happy? Are you content? Are you doing the stuff you'd like to do? Same is true of children. Same is especially true of children, right? Because I don't know if you've noticed, but they get bored easily. And so we kind of got to keep their interest up. And there's one of the big sorting processes for a lot of families is this is a personality game. And if your child connects with that person and they can motivate them to do things that you can't motivate them to do, hey, there's a win. If you're going to a therapist and they're just not into it, you may not be making that much in the way of gains. And so we just these are things we have to balance out in the big scheme of things, but never forgetting that this process is a reciprocal dynamic. If you sit in a dark room all day long every day, you're going to get really good at sitting in dark rooms all day long every day. And that was the fate of a brain injured child 15 years ago. It's important because every one of us is a distinct individual. We all have personalities that come out. Our children are the best of us and the worst of us. And an important thing that we have to take into consideration is how does this human present themselves in the world? What does this consciousness look like? What is that personality? What's involved in that? It might be just peevish and grouchy sometimes. Sometimes it's just hilarious and joyful. These are important elements that we have to take into consideration because these small little fragments of nerve tissue that's at the peripheral edge of the neurology that we have is where we reside. The us that is the us, right? This is what we got to preserve. These are the parts that we want to make sure stay intact as much as possible. And the quality of that material is based on the quality of the materials it was made from. And 90% of your neural architecture is in place by the time you're 5. We have a kind of an issue. Some kids are picky eaters, supposing they get a choice. Chicken nuggets aren't really great neural architectural feeders. But they're marginally better than most formulas on the market. That's unfortunate. A lot of formulas are designed more so to fill some gaps, fill some spaces, blank spaces, if you will, on the form of, do you have this element? Yes. Do you have that element? Yes. Is it digestible? Oh, that's not a box. So what does it mean to talk about a comprehensive approach? Well, really that means for our clinic, it is we are primary care physicians, and we deal with whatever walks through the door in whatever day. And so because the patient base that we're talking about are, kids that have neurologic injuries. A lot of times we're doing management of trach tubes and G tubes, and we're talking about why this formula may not work for this person and what else we can do about that and how we can change this part of it and that part of it. That's the comprehensive, right? It starts with how do you sleep? How do you eat? How do you move? Those are the three biggies. They are the center of a sense of agency in a human. If you think about it, there's really only three things that any one of us has absolute control over in our world. And that is what we eat, how we think, and how we move. Agency is what we're trying to inspire in the children. We want them to have that sense of agency. And we want to establish kind of what does it mean to have that, and how do they get some kind of feedback so that in that sensory world, they're remodeling themselves with that sense of agency. So part of the toolbox that we employ is just a reallocation of resources from one place in the body to another place. We've got a damaged area, we've got a lot of non-damaged areas. So can we take something from one place and put it in another place and allow that to accomplish some objectives? A lot of times the answer is, yeah, we absolutely can. There's this concept of autologous therapies. In our world, autologous therapies just mean we took something from you, from one area of you, and we put it in someplace else in you. That's all. Because it's all your stuff, then there's no rejection factor. Because we're talking about tissue transplants and encouraging certain kinds of tissue growth, that rejection factor becomes really important. And a question that we should always ask if we're talking about tissue transplants of any kind is, hey, look, if this person was to give you a liver, would you do okay with that liver? If a random person gives you their liver, don't take it. However, we have a marketplace that says that it doesn't matter, you can have a random stranger's stem cells and they'll be fine in you. Will they? So PRP is a particular form of processing platelets into a form that allows you to capitalize on some growth factors that are normally present in plasma. All of the literature on PRP has been done with adults. So we're going to talk about some of that stuff. I'm going to move through it really fast. Some of it's technical. If you got questions, by all means, raise your hand, holler at me. We'll work the heck out of that. So by definition, a PRP is you've taken a blood sample, you've spun it down, and then you've concentrated the platelets. Platelet-rich plasma. Why the platelets? Well, the platelets themselves are the currency of trauma and the currency of healing. If you cut yourself on your arm, who's going to show up to create a clot, get that wound to heal? Platelets are. Platelets contain something called a platelet-derived growth factor that turns out to be a pretty great stimulator of wound healing. In order to accomplish a PRP, you pull a blood sample, you get some plasma, and then you concentrate that down about 5 times. We'll talk about what that really means, because there's a lot out there in the world as to what's PRP, what's not PRP. Do you care? Maybe you don't. Maybe you do. Sometimes it's semantics. What we do find is that this magic number of 1 million platelets seems to be significant. Most of us on a blood test will have platelets that sit somewhere in the range of 150 to 450. That's actually the literal range. And so depending on that, you might have to concentrate your sample a little more or a little less, but you're looking for 1 million. This slide's a little bit of a misnomer. We won't spend a lot of time on it, but I just want to say this little blue part right here, never, ever, 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 ever have we seen that blue part be that big. That's usually a very small part. However, this buffy coat here also usually sits right on top of this red blood cell. Just technical, because when you're pulling that up, this becomes the important player. There's a lot of hype in the world about stem cells. Oh, stem cells, they'll fix this and they'll fix that. Oh, stem cells are the way of the future. All you gotta do is get them in you and they'll fix everything that's wrong with you. Probably not. Essentially, a stem cell, just a brick. A pretty interesting brick. It's a brick that can take on any shape, that it might need to take on, and it can become whatever kind of brick you might need. Still just a brick. Not really much in the way of brains. They're driven back and forth in a system by trauma. That's their primary messenger. And when we invoke something like that, the trauma element becomes important because that's where the cells end up being directed towards. Platelet-rich plasma gives you the opportunity to sort of present some trauma. Is it really trauma? No, you just concentrated some platelets. But do the tissues at the site that you might put something like that know that that's not because of some trauma that just happened? They don't. They think that whatever you just poked that person with is a problem, and they mobilize an immune response. That's important because we talk about the platelets, but really it's these white blood cells that are involved in the remodeling process. We talk a lot about stem cells. Stem cells are a raw material that requires a contractor to put them together in the right ways. If you just have a delivery of raw materials, you may not get a remodeled bathroom out of that. So who runs this show? Well, these guys run this show. Your T cells, and mostly your CD4 cells are involved in that process. But that's a whole nother conversation. Platelet-rich plasma, by definition, you're pulling it, you're spinning it down. And a few years ago, the question started being asked, what if you put this up somebody's nose? What if you gave it to them IV? Would it do something for their nervous system? It turns out that actually it does do quite a bit of stuff for your nervous system. And this is variable depending on the quality of the sample that you're getting. And children have a lot of growth factors floating around inside of them. And they tend to have a lot more free-floating progenitor cells than other folks do. Older folks, I should say. So we know, study-wise, that PRP does help with regrowth of brain collagen, activation of the targeting of stem cells, angiogenesis, which is making new blood vessels into areas. They decrease inflammation. Often that intranasal delivery of such a thing is really helpful for kids that are neurostorming and when you have a blood-brain barrier that's been compromised. So essentially, PRP has been around for quite a while, and there's been a tremendous amount of studies done on PRP for all sorts of purposes. Originally, we were doing this in an orthopedic sort of a way. You tore your biceps tendon or you tore your whatever rotator cuff, and we put a little bit of PRP in there, and what you find is that that allows us tissue that doesn't have a great blood flow to get nutrients that it normally wouldn't have gotten, and so now it's able to restore itself. And we find that that happens really in the vicinity of administration. There's an important element there because where you put the stuff does make a difference. There's a lot of components of PRP, lots of growth factors. And there's also a few monocytes. Some of those monocytes can represent a stem cell. Now we move into a marketing realm that the FDA is really unhappy about. Basically, FDA tells me, if you utter the words stem cells, we think you're lying about something. They're not wrong. Next to the bank, in the little strip mall by my office, is a little CBD place. And they have a little placard out front that says, we have stem cells. I'm sure you do. In the same way that Fry's has stem cells or Albertsons in that they have apples in their produce section. So what happens is we popularize terms so that they don't mean anything anymore. Two companies got popped yesterday by the FDA because their reps tell people, oh, there's stem cells in here. I've had both of those companies, by the way, are in Phoenix, where we live. And I've had conversations with the reps of those companies who come in and they say, oh, this is a stem cell product. All right, it's $500 for this little vial. Tell you what, I will open this and we'll put this on a slide. And if we find one cell, I will pay you the $500 for this vial. If we don't find any cells, you pay the $500 for the vial. Oh, we don't want to do that. You don't? How come? Because by definition, if you've got a cell in that product, you contaminated it with something. There's no cellular material that can survive that process. It's not. So They got busted by the FDA yesterday, and we'll see how they survive. Because we don't need more regulation. We might need a little. We might need at least to educate a public about, hey, people will tell you anything to sell you something. This is an election year. Make no mistake, you, my friends, are being lied to regularly. Every one of us is being lied to. It has become our culture now. Lying. It's tragic. So, stem cells. You got a couple kinds. Yours and not yours. If they're not yours, if it's wet and not yours, don't touch it. That's just a rule in our household. Every tissue in your body came from a stem cell of some kind, right? Because these are the original progenitor cells that come out of embryos. How does a stem cell know that it should become a liver or brain or muscle? Well, it depends on where you put it and what the dominant messaging system is in the area you put it. If you pop it in the middle of a muscle, you're more likely to come up with some additional muscle tissue. If you put it in a nervous system, you're likely to have some impact on nervous system. Does that mean you're growing neurons? Maybe, maybe not. Does that mean you're growing, say, glial cells? Yeah, that's provable. So we call these mesenchymal stem cells. Fellow Kaplan, he recently passed, who named them originally, was asked to redact the paper and to change the name. And this is how regulation kind of happens in these kind of avenues. So a mesenchymal stem cell just meant mesenchyme is embryonic tissue that's all through you. So these are cells that are everywhere, essentially. However, the petition that was made to him, Dr. Kaplan, from the FDA was, we need to change the name of this. We'd like to change the name to a medicinal signaling cell. The literature can stay the same. It can always be MSCs. But the Food and Drug Administration, once you call something medicinal, now it's in their domain. Do you see what happened? Does anybody care what happened? Just changes the pocket of regulation you might find yourself in. When the FDA talks to me about it, they say, we would like an existing entity in the industry to take this project on and standardize it. You mean an existing entity that's not me? Is that what you mean? Because that's what I'm hearing. Basically, we want somebody who's got $1 billion budget so that if things go wrong, they can pay some people off. Oh, that's their medical system. So you can get these things from a lot of different places. Originally, we were pulling MSCs from bone marrow. They're not MSCs if you're getting them from bone marrow. They're hematopoietic stem cells at that point in time. You know, the thing is, you're drilling a hole in someone's hip bone. Pretty much that hurts. The great thing about small people is they don't have such solid hip bones. It doesn't hurt any less. Doesn't hurt any less. And maybe you can numb it up in the moment superficially. You're not numbing that bone up. So you've got to put them under. And that spot's sore for 6 weeks. That's how long it takes for a bone to heal. There's some subtle differences between hematopoietic cells and mesenchymal cells. We used to think that a stem cell is a stem cell is a stem cell, and it'll all just become whatever you want it to become. Yeah, that magic box is opened up. It isn't like that. There is a proclivity that certain tissues will have depending on where they come from. So if you come up with hematopoietic cells from bone marrow, they're really good at becoming blood-making tissues. If you got chronic anemia, aplastic anemia, what have you, they're pretty good at that. Multiple myeloma kind of stuff. Mesenchymal cells are more evolved in, say, connective tissue sort of activities. Even though we're pulling them out of adipose tissue, it's still that stromal vascular fraction is what we call we'll talk about that, a different tissue line, the SVF. So depending on where you get it, you can get a certain number of stem cells. Does that mean they'll do anything? It doesn't. They're bricks. They're entirely dependent on the environment that you put them in. Really, 2002, Patricia Zook, this is her original paper, is who kind of blew the doors off of this in 2002 for people in the US. The truth is that everyone else had been doing it for about 10 years. So in 2008, which is when the moratorium on stem cell research was lifted in the US, mostly because of ignorance, the moratorium was established during the George Bush administration because of a misunderstanding that all stem cells had to come from embryos, and if you're going to approve stem cell therapy, then you're approving abortion therapy, and that can't be right. It's like, whoa, hold the farm. We've known for a long time that you don't need to kill babies to do this. All of us make this. We all make these cells. Some of us make them better than others, but this is not exclusive to that. But because of that misunderstanding, we allowed the rest of the world to get about a decade ahead of us. Fortunately, most of them are pretty kind people, and I had really good conversations with a lot of them when we were establishing our process in 2007. Not that we hadn't been doing some other things in the realm. It was more specific to cell work, and we wanted to do it right. So the stromal vascular fraction now, which is basically this portion of fat that you get when you spin down that sample, allowed us to treat just a little bit shy of 1,200 people. And we shared that population with some people in Eastern Europe, and we were able to write this paper almost 10 years ago now. The writing of the paper was actually 10 years ago. The publishing of the paper was in January of 2015. And so, and it was really about 2 years that it took us just to kind of compile the data in a way that made it look like, hey, something's going on here. Essentially, what we found was a 92% success rate, in as much as the structure that was impacted had definitive changes on imaging after the treatment. So we knew, okay, it does something. It does a thing. What nobody really knew yet was, so for arthritis, this is great. Does it do anything for neurologic issues or other kinds of conditions that people might have? Well, there was value in this, right? Because we could get this sample painlessly. I mean, we can numb a person up and suck some fat out. And the first time we did that, like when we were doing bone marrow, we'd get 300,000 cells on a really good day. First time that we did a fat biopsy, not knowing anything about what we were doing, we got 5 million cells. I'm like, oh, my goodness, this is the mother load maybe. And so then we start trialing that. Of course, we get a lot more than that these days because, anything you do 100 times, you're going to get better at. And now there's a thing called nano fat. And my staff and I, the other physicians and I were privy to a conference this year in August in San Diego that was sponsored by a company that caters to plastic surgeons and orthopedic surgeons. And all of the presenters were plastic surgeons and orthopedic surgeons talking about this magical thing called nano fat that, did you know, this has some stem cells in it. And the orthopedic surgeon's like, I have a 92-year-old guy that had a spine break, and we put this into his spine break and it healed it. And here's your images before and after. And you're like, no joke. Who knew? The plastic surgeons, oh my goodness, we saw 15 ways to do a facelift. Wow. I'm glad my job isn't doing facelifts. However, it's sort of the coming of age of a therapy, right? For a long time, it's like, you guys are quacks doing that stuff. And then it's like, some orthopedic surgeons and some plastic surgeons come in. Here's the thing about plastic surgeons. They don't care. If people are going to buy the product, they're going to sell the product. They don't care that this may or may not be approved by the right folks, right? These are people who are like, bring it on. And we'll call it whatever you want us to call it, but we're using this because they're sucking fat out of people. And they're like, we're throwing this stuff in the garbage. There's some good stuff in this fat. And so here's a whole conference, 4-day conference, presenter after presenter. We did it because there was a cadaver lab also where we were doing some pain therapy injections into neurons. Nano fat's kind of a thing. And now there's literature happening, nano fat. FDA's got wind of it and they're like, ooh, we don't know how we feel about this. But part of that process is establishing that indeed there is a usable amount of cells in this material that can be very beneficial for some purposes in humans. You're reallocating a resource, right? And so these mesenchymal cells can become all of these different kinds of tissues depending on what sort of environment they find themselves in, what kind of growth factors are available in that environment. How are we doing on time? I don't have a clock. Oh, it's the biggest thing on the wall across from me. Wow. So, this isn't rocket science. You're sucking some fat out. Some kids don't have a lot of fat. Fortunately, there is kind of an inverse proportionality, so that if you don't have a lot of fat, it tends to have a higher concentration of cellular material. So some of that does end up working out, but sometimes it's tricky. You have to anticipate that. We get specific about how we do this with pediatric patients just because the nano-fat folks are doing it in a lot of folks. And they have a little bit of a different process. And so for us, it's important that number one, we don't increase the traumatic experiences for this human. And that's easier said than done when you're doing a medical procedure with somebody who's, maybe not understanding what's going on with them and may not be all that cooperative in that moment. But we want to make it so that it's not more trauma to this individual. And so we try to take special pains to make sure that they're as anesthetized as possible. And sometimes we cover the adults in the anesthetic just to say, hey, which one works better? And then we touch our mouths, and then we all have slurred speech, and boy, it's a good time. So essentially, these are our falcon tubes. The first indication that a stem cell was even a thing was the comment in the part of a laboratory that was doing some cellular work, and they said, whatever these cells are, they strongly attach themselves to laboratory plasticware. Oh. So glass vials, quite frankly, don't work quite as well as the plastic ones. I have a lot of mixed feelings about that. But what'll happen is your cells concentrate down in the bottom of these falcon tubes. And that's a really convenient thing that they do. And so you can get cells from a lot of different places. It doesn't mean that they're going to do the thing you want them to do, but as you do so, try to make it so that you're not causing more pain and more issues in the extraction of it. When we look at SVF, similar to the PRP, we see a lot of cells that are involved in remodeling as well as in making blood, no matter where you get them, as well as a whole lot of growth factors and growth proteins. The concentration in an SVF is just several times that of a PRP. When with our patient base, because this is part of our ongoing data collection, we always take a picture of those cells. And one of the things that we try to do is blow them way up and get a really good look at the morphology of those cells. Of those red blood cells, whoops. Oh my goodness, I went way back. So you see this little guy right here? Does not have a nucleus, doesn't have a bunch of stuff inside. Versus its neighbor, which has a lot of mottled appearance. And if you spend enough time and you focus on the cell, you'll see the emergence of a nucleus in there. Versus here again, this is a red blood cell, that's a red blood cell, these are mesenchymal cells, that's a red blood cell. And the way that you can tell is generally red blood cells don't have junk inside of them, and every other cell does have junk inside of them. When we do the count, it's tricky because you're taking some of this precious sample that is more valuable than gold to this individual so that you can do this thing and look at the number of them. But it is important so that we know kind of data-wise, what are we getting? And what changes that process? 10% of our sample is administered postnasally so that it can go across the blood-brain barrier. It also has an impact on the blood-brain barrier. And then the rest of the sample, we end up putting in the sacral foramen. It just happens to be a convenient out-of-the-way location where we have a passive communication with the rest of the cerebrospinal fluid as it flows through the nervous system. A lot of questions get asked for us about, well, how do you know they go where they're going to go? I'm going to go to this clinic and they do it IV, and then they do it IV, they go exactly where they need to go, and they don't go anywhere else because the brochure said so. And then the people, and I tell people, I can't guarantee that. Well, I'm going to go to this other place and such because they can guarantee that. And I don't think they're guaranteeing that. And then they come back 3 months later and they say, well, this isn't working. Well, I don't know what to tell you, but you went to a place and they made you said a thing and that thing was not true. And that happens a lot. So it's not like there's not literature about this. When we give IV stem cells, big proportion of them end up in lung tissue. A secondary large proportion of them end up in spleen tissue. We do get somewhere between 7.5% and 8% of those cells making it into the brain, but that's not appreciably larger than any of these other tissues necessarily. So if I put something in an IV and I give it to you, does it cross your blood-brain barrier? Maybe. Depends, right? Depends on what it is. Is cellular material that goes in IV going to cross the blood-brain barrier? Not a chance. Not a chance. Too big. The very thing that a brain's trying to keep out of itself are white blood cells. It's important because once you've programmed T lymphocytes, then you can let them in because now they're programmed. But unprogrammed T lymphocytes, as they get across, they wreak havoc. And cause encephalitis and encephalopathies. And so you don't want that. And so your system is working when it's keeping those things from going into your brain. If you have a lung condition, IV is the way to go. And for some of our kids that are affected that way, a lot of our cystic fibrosis kids, a lot of kids that have respiratory issues after a near fatal drowning, sometimes that's what you need is just to get an immune response in there so they stop getting sick and they can stay out of the hospital long enough to actually do some therapy. Because what fixes people? Nothing fixes people. We grow, we evolve, we transform. And what do we use as the basis for that? What you did yesterday, what you did the day before that. Therapy. Therapy is the only thing that gets us to a better place, right? If you're not happy with your upper body strength, what do? Well, you might go to the gym and lift some weights. Just wanting your upper body strength to get better, is that going to do the job? It is not going to do the job. Just wanting a child to get better is not going to do the job. If that child can do the work, if you can find the right people in their world who will assist them in doing that work and motivate them. And the greatest therapists are the ones who can motivate your children to do the stuff that you can't motivate them to do. Right? I mean, this is the challenge of being a parent. Is you love this little human with all of your heart, and yet they will listen to a perfect stranger better than they will listen to you. It's the parenting conundrum. So what draws stem cells into any area? Trauma. So what we'll end up doing is if we do a transplant of some cells, some white blood cells with some mesenchymal cells, then about 3 months later, we recognize that those guys, as time goes by and there's not like a lot of trauma happening, they get lazy. It's a conservation of resources. So after about 3 months or so, if we can go back into the same places that we put some cell depots and put some PRP in there, that wakes them up. Here's your trauma. Wakes them up and then they start getting more active. Sometimes we see more changes in kids after we do PRP post autologous tissue transplant than we do when we do the original autologous tissue transplant. So mesenchymal cells are amazing. They don't do much by themselves. So a lot of this research that gets done that talks about how great they do, like they're known to exert an anti-proliferative, immunomodulatory, and anti-inflammatory effect. Are they though? Is that what they do? I would say no, they probably don't. What does do that are white blood cells. White blood cells are involved in all of these processes. But they're not so flashy. What's fun is to talk about stem cells. White blood cells, but they're the real players. MSCs definitely, though, proliferate and migrate and differentiate. And so anytime you put any cellular material into any space whatsoever, it doesn't matter. If it supports the growth, then that tissue is going to do one thing and one thing alone. It's going to grow, 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 grow. It's going to expand, expand, expand until such a point it reaches some finite resource. That might be space. It might be blood supply. It might be glucose. It might be oxygen. Who knows? But once you reach that wall, now you've initiated a differentiation process. That is, some of those cells have to become something else to tap into a different resource base. That's your driver for an evolutionary change in these tissues, and that's really what you want. So, one of the criticism has been, there's no research on these. Nobody knows anything about this. This is all brand spanking new. Yeah. A little search will reveal a lot has happened, especially in the last 10 years. Like, where's the date on this? So a lot of this 2015, 2012, 2017, this is a 2015. We've learned a lot. What we've learned is that it's not an unsafe thing to do. Originally it was, oh, you give stem cells to people and you're going to grow tumors. Well, we haven't seen that. Could it still happen? I guess conceivably, but in our population base, we really don't see that. Blood-brain barrier, the disruption of the blood-brain barrier for a lot of kids is a cause for neurostorming. It's also a cause of seizure activity, especially when they're triggered environmentally. So your blood-brain barrier is a filter. It keeps some stuff out of your brain and lets other stuff into your brain. And so if the guy in front of you at the movie theater is wearing Old Spice and you feel like you want to have a seizure and rip his eyes out, that's because your blood-brain barrier is allowing a little bit more of that in than it would like, and that's irritating your nervous system. It's a big deal because perfumes are a cause of seizures in children. People don't get it. I'm gonna put as much of this perfume on me because I want to smell like that. I want to smell like a seizure causer. That's what happens. We've had to tell therapists, hey, stop it. You can't wear that because you're causing these kids to get sick. It's a big deal until you get the blood-brain barrier back to a good place. And that's like Tuesday was good and Thursday's not so good. Hyperpermeable blood-brain barriers cause all sorts. There's too much material coming in, it's overwhelming, and the brain kind of shuts down. It'll cause some seizure activity, even headaches and migraines, fatigue. If you have too less permeability to the blood-brain barrier, which sometimes is the way it works, then you're not getting nutrients in, you're not getting beneficial items in either. And we know that if you put some tissue up through the nose, that you can get pretty direct access to that blood-brain barrier, and you can influence its level of inflammation. In that case, and when we put the depots in, we use a series of hydrogels. Hydrogels are just compounds that are slippery on the inside, and most of them are the base products of connective tissue. We use hyaluronic acid quite a lot. Hyaluronic acid becomes famous because it's what Wharton's jelly is made of. You've maybe heard of Wharton's jelly. It's another one of those products that's out there that has no cellular material in it, but people will pay a lot of money to get it injected into them. We make it ourselves from scratch, and it's a really nice matrix for holding things. If you're gonna put hyaluronic acid, which is also a facial filler in your wrinkles, that lasts about 6 months. Some people it lasts 3 months, some people it lasts 9 months, but your average is about 6 months. So FDA tells us that if you're gonna use this as your depot to put those cells in this space, then probably doing it more than every 6 months is reaching a point of diminished returns. So that's why we do it about every 6 months. That doesn't mean we hold to that absolutely. Sometimes we'll do it earlier depending on the particular situation. Sometimes we'll do it later. Point is that we're trying to have a sustained release effect so that those cells are continually being deposited into the nervous system over that 6-month period of time. It turns out that hyaluronic acid is the material that's also in an embryo and allows migration of cellular material really well. And so we use it for that purpose. Ours is a vegetarian source of sodium hyaluronate, by the way. Otherwise, it comes from cow eyeballs. Which is fine, but really expensive, because I guess it's a lot to get it out of an eyeball. Plus, people tend to have a little bit more tissue reaction when you use animal-based products versus if you don't. Hyaluronic acid is a very common polymer. It's slippery. It's what lubricates your joints. So it's a part of synovial fluid. It's hydrates tissue, lubricates tissue. It also allows for cell functioning and differentiation. And that's really a big appeal for us. That hydrogel then allows us to coat a damaged structure with something that's biologically compatible, and we can put a little bit of a PRP, we can put some cellular material in there, and we can say that's gonna be on that nerve for such and such amount of time. It becomes important because nerve damage in the peripheral nerves happens as a result of dystonia, happens as a result of injury, and also happens as a result of what we call medical misadventures. We have a fellow, he's not a child, he's a fireman, actually from Oklahoma, who was in a burning building and a beam fell on his leg, and it caused a drop fit. He's a firefighter and a semi-professional bowler. And so this beam coming down severed the lateral sural branch of his sciatic nerve and right about there. And he could feel like where the numbness begins and ends in there. And it had happened not terribly long before I saw him. And he had to retire from the fire department and he couldn't bowl anymore. And so I told him, I said, if we can find that nerve, then, and it's a big enough nerve that you can find it on ultrasound, and we can fill that gap, maybe we can get those tissues to migrate together. The next I hear from Mike is he sends me a article from his local newspaper talking about how he has just won this huge bowling tournament because this retired firefighter was able to go back to bowling when his drop foot resolved as a result of that treatment. So we know that putting stuff on a peripheral nerve definitely helps assist that in getting those tissues to migrate together. All right, so point is, if you got a damaged nerve, there's stuff you could do to that damaged nerve, and even peripherally. We also do a thing called hydrodissection. Sometimes a nerve will be covered over with scar tissue, and that happens a lot, especially in shoulders in kids. If your 3-year-old, 4-year-old isn't crawling, and they won't use that right arm or that left arm, consider that there was maybe an injury in that rotator cuff. We just had a situation where we did a complete musculoskeletal ultrasound exam on a little girl who was not using her left arm. We found a very distinct subscapularis tear, which is a rotator cuff tear. It's the muscle that does this kind of thing. And it's a stabilizer of your muscle, of your shoulder. If you want that shoulder to bear weight, you'll need the stabilizers to be able to be intact so that they can bear that weight. And she doesn't bear weight on that shoulder. We put an ultrasound on there. Sure enough, that little subscapularis is torn very clearly. So I get some, what I think are beautiful pictures. We put them up on the ultrasound machine. We make copies of them. We write up a little report. We send it off with the family to the orthopedic surgeon, not that she needs surgery, just so they know that this has happened. And physical therapy will probably do this, but we've done some injections in there, and generally these things heal up pretty well. Orthopede says 3-year-olds don't get rotator cuff tears. I'm not looking at those pictures. Go home. I said, all right, take your pictures to your physical therapist and take your pictures to your chiropractor, and I'm sure you'll have more satisfactory results, which they did. They were like, oh, this is great. Okay, physical therapist sets up a nice rehab program for this subscapularis. Chiropractor's doing some adjustments. They're working that, doing some physiotherapy. We get some other therapists on board. Arm gets better, kid starts crawling. Do 3-year-olds get rotator cuff tears? Yeah, if they got horrible dystonia, and here again, you're trying to put their arms through sleeves and stuff, right? Or you're getting them in a car seat and they've got the limbs that and things get damaged. I mean, that happens. This is not rocket science. So sometimes scar tissue will build up in an area because the injury happened and yet the child still is held in what we call an antalgic position. An antalgic position is when you hold your posture in a weird way because it doesn't hurt that way and everything else hurts, right? So an antalgic position is, okay, you're in pain. Let's figure out where you have pain. Sometimes in little humans who don't tell you, it's hard to find where that pain is. We do a physical exam, maybe you poke the right spot and they're like, oh, okay, that hurts. Did you gain anything from that? Not necessarily. So sometimes what we need to do is look at what's happening inside of those muscles. And that's really where diagnostic ultrasound comes in handy. And I'm jumping to this because musculoskeletal ultrasound in here, we have another one of those areas where this is an underserved population because there are no pediatric musculoskeletal ultrasound specialists in the United States. So we recruited a company, orthopedic ultrasound specialists out of Los Angeles, and it's a husband and wife team, and they come to our place every few months, and we sit down and we ultrasound small children with different issues. And the idea is, can we get to a place where this is automatic for us? And for myself and several of us that are in the office now, we've been doing this for 2.5 years. We've gotten pretty good at finding things. And now we're helping to teach the younger incoming residents and as well as other physicians in the community, here's how this works. And the technology of ultrasound has come so far in the last several years that it's amazing that what you can see now with ultrasound. It used to be you were just hunting white rabbits in a snowstorm. And now you can actually see the structures and you can get a really nice definitive look at what's working and what's not working. Here's the best part. I can move them. If you're doing an MRI or CAT scan, you can't move them. How do you know functionally how this thing works, right? Get a hip x-ray. Oh, don't move. Oh, I could put a probe on there and I can move that leg in all kinds of directions. And I can tell you, hey, your external hip rotators are tight. That's what's rotating this hip backwards. And then your adductors are tight. So now, because this has dislodged the head of the femur from the acetabular socket, now the adductor, as it puts pressure on, it can pull it out. If you didn't get this in the first place, this isn't usually strong enough to pull that out. So it's a double whammy. Oh, we look at it in an ultrasound and say, hey, can we release that piriformis on that left side? Can we release that iliopsoas that's stuck under an inguinal ligament on that left side? If we can do that, could we get more normal motion out of that hip? Could that person potentially now walk, stand in a gait trainer? Could we reorient the head of that hip so that it's better suited to the socket, so that as you're in a gait trainer, as you're in a stander, that hip bone is actually pushing into the socket? Because the ticket there is pushing into the socket deepens the socket, and the ball being there rounds the ball. Now you have a more normal looking hip because it's being able to do normal hip stuff. Versus if they're discombobulated, now you're not getting the pressure that gravity would allow for a hip to develop properly. And then that bony projection that's the ball isn't so ball-like anymore, and that pocket becomes shallow. And now you don't have a good stable hip. If you recognize the structures that are involved in the dysfunction and you can get that early enough and we can stop that, that makes a world of difference in terms of being able to walk when they're 12, when they're 10, when they're 8. I'm going to back this up a little bit now. Because the ticket is, how do you know where to put the stuff? If you don't have some kind of imaging, something like collagenase, hey, we're mostly collagen. Collagenase, an enzyme tells you what it does. And ACE cuts things, and the rest of the name tells you what it cuts. We're mostly collagen. You'd want to be really careful about where you put this. However, if you have a contracture in your wrist, in your ankle, right, and this will not open up because this is stuck, I can put a little bit of collagenase in there, open up that scar tissue, and get it to open now. We don't need surgery for those contractures any longer. Most of them will respond to that kind of injectional therapy really well. And there's a beautiful paper that was just published on use of collagenase in foot issues in adults using diagnostic ultrasound, musculoskeletal ultrasound, in order to know where exactly to put it, and with about 100% success rate, so long as the person doing the poking is poking in the right place. So we have two sides of a coin. Hyaluronic acid, or hyaluronan, is jelly, and that's nicely lubricating, and it carries things and it holds things. And over time, if the jelly gets in certain places and that place isn't moving, let's say, for example, a tendon in a tendon sheath, as that tendon is tight, as a muscle gets spastic, its length shortens and its girth thickens. Same amount of material, just covering a smaller span of space here, so it's thicker here. There's a sheath on the outside of that tendon that lubricates it with some synovial fluid, which contains some hyaluronic acid as its main component. And when it's working right, this thing moves in there frictionless, and the ratchet works beautifully. If you're not moving this, then over time in that tendon, that hyaluronic acid dries up, it becomes a glue. And it sticks that tendon to the inside of that tendon sheath. Now, you can still move the limb, but you'll be limited. You won't be at the full range of motion. And when you feel that tendon, like you feel your tendon, you can feel it slide through the sheath. In their case, you don't feel it. You feel it up here. Oh, it's sliding. Oh, it's not sliding. Sliding, not sliding. Put an ultrasound on there. Oh, sure enough, we got a little lesion right there. You can see that then as you're moving the limb. If you're getting a static MRI, you're not moving the limb. You don't know that is a problem right there. You're getting a CAT scan, you don't know that that's a problem there. There is no other indication other than you move it, you watch the structure move freely through its whole length, now you're winning. If you don't do that, you're not. I don't know of another imaging technique other than musculoskeletal ultrasound that will allow you to do that, which is why we've invested so much into that kind of a process. How, when you have hyaluronic acid that's become dried and crusty and holding your tendon together, what do you do about that? Well, there's an enzyme. Remember that enzymes tell you what they do. And ACE, cuts something up. The rest of the name tells you what it cuts up. Hyaluronidase is an enzyme that specifically cuts up hyaluronic acid. So Dr. Raghavan, Preeti Raghavan, at the time that she did this research, she was at New York University. Now she's at Johns Hopkins. She's a very brilliant individual. And she says, look, like, I don't know if I'm doing something. Wow. And so she says, I think we're thinking about this wrong. She says, this dystonia thing, and she's talking about adults. She doesn't deal with children. She says, this is dystonia thing. And she's talking about adult cerebral palsy patients. She's like, this isn't all from brain issues. There's something that happens peripherally because of the brain issue that then causes this structure not to move properly. She's really the one who blew the doors off this idea, because if it's a brain issue, sorry, there's nothing we can do about it. If it's a limb issue, it's let's take a closer look at that, because maybe we can do something about that, right? Shift in mentality from the old days of take your child home, there's nothing that can be done, good luck, enjoy them while you have them. Diagnose and adios, Dr. Harch. There's so many more options, and this speaks directly to a quality of life and a sense of agency, an ability to move. So she presents the hyaluronan hypothesis, which is, hey, look, sometimes these structures don't move enough to keep the lubrication lubricating, and as it dries out, it gets stuck. Sometimes we've had people, I had a little guy in the other day with an iliopsoas, his leg's here. Mom's like, I can't do any therapy. He did hip surgery. The surgeon says, just keep pushing it down, keep pushing it down. She says, he screams bloody murder when I push it down. So she's like, I don't really want to do that. The surgeon's like, well, you got to keep pushing it down. She's like, we can't do therapy. We can't do anything. He can't even crawl right now. Okay, before you leave this place today, we will have this leg back to functioning. She's like, really? Yes. And so first thing you do, you put some topical numbing on there, put a little cream on there just to relax the tissues, get some blood flow in. Interesting thing about blood flow is it takes no energy to contract a muscle. It takes all of the energy to relax the muscle. That's why a body goes into rigor mortis when they die. Because there's no blood flow, there's no neurologic input, structures all just get stiffer, 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 stiffer. So, blood flow into and out of those structures allows them to relax. Have you ever had a headache from your shoulder tension being so tight and it's been like shoulder tension for days and now it just won't go away? It can't go away. Someone's got to punch it. Someone's got to rub it. You got to rub it, maybe. Maybe you need an injection, maybe something. Anything that'll break the cycle is getting blood flow into there. As soon as you get blood flow, now the structure can relax. So long as it stays spastic, the structure itself is depriving itself of its own blood flow. Because if you have to overcome the pressure inside of the structure to get blood flow into it, and let's say you're pumping out blood, let's say you're just pumping it out 120 millimeters per mercury, which would be a normal blood pressure for an adult, is that going to be enough millimeters of mercury to get that material into that spastic muscle? Probably not. And if it isn't, then it's going to stay spastic. So sometimes we have to make interventions right there to that site. And there are some common sites. This is specifically for shoulder dystonia and considerations for when a limb is here. We have a 14-year-old who, 9 months ago, was exactly here. And every month I see him, and we've got this arm now. This left arm is now out, and we can get it probably not full range to complete external rotation, but it's there. It's on his own volition. It's able to do its thing. So now he's able to do things like use his walker. Thymosin beta-4 is a component of our tissues. It's also something that we oftentimes add to the samples. This is an increaser of actin laying down. This is what gets muscles to build themselves really quickly. And NFL has considered this a banned substance. In tiny 4-year-olds who have stringy muscles that aren't able to compensate for the load that they're under and all their spasticity, sometimes just getting a little bit more muscle mass, and they can relax because there's not so much of a load. So part of this is also how do you manage a remodeling process? Let's assume we're putting things in that are going to generate new neurologic material. What's the quality of that new neurologic material going to be is really dependent on what kind of resources are available to make that new material. And we know that myelination of nerves is a really big deal. Myelinating a nerve allows it to conduct current at a much, much faster rate, because when the nerve, consider it's like a wire, when the wire is insulated, now you don't likely lose that current in the curtains behind your couch as it's making your lamp go on. Now your system is able to control that current. Tics, seizures, aberrant electrical activity in the nervous system is a product, in most cases, of poor or reduced myelination in that area. So part of the land race is we're initiating remodeling. How quickly can we get materials into that individual to encourage myelination so that the structures that are being remodeled in new structures are competent to carry the current? Sometimes that's a tricky situation because sometimes kids remodel their brains faster than you think a person should or could be able to. And then sometimes you get some aberrant electrical activity. And so therein we need to increase the amount of the materials available to create the myelin sheath to protect those structures. It's important because the nervous system doesn't know there's a glitch until the current gets lost in that glitch. And that's your indication that, oh, this needs to be refurbished. And that's how a brain remodels and really heals itself, getting the right resources, drawing on a demand on the part of the rest of the body in order to facilitate actual healing of the nerve itself. And so part of what we end up doing is creating different preparations that could go into a person. And you know, you can have the best things in the world go into a preparation, and it may not work for 100% of people. In fact, I could personally guarantee it's not going to work for 100% of people. And this gets to the crux of why I think a lot of us are here, is there's a lot of options. There's a lot of newer options. It's hard to sort through a lot of those options. It's overwhelming. So part of what we have to do is start with today. What is this person's quality of life? A small human presents themselves into our office. A comprehensive intake kind of involves, how's the family doing? Hey, if you've had a near-fatal drowning, there's a lot of grief in that household. There's a lot of potential blame. There's a whole lot of guilt. There's a whole lot of crap that goes along with that. And the truth of the matter is that you've got a small entity coming back into this world to live in their body. And if it's a comfortable environment that they're coming back into, they'll be a lot more inclined to be there than if it's an uncomfortable environment. If a house is riddled with sadness and tension and grief, that's not the place that a child necessarily wants to come back to. And it's a tricky one, right? Because how could you not have grief after a traumatic incident happens to your precious child? Or with birth trauma, sometimes that grief it's different because that child doesn't necessarily know another way of being. But the grief is very real for people. It's like, hey, my hopes and dreams, this is our children, right? They're the best of us, they're the worst of us, they are us, right? They're the next generation of us in the same way that we're the generation of our forebears. So we start with, what's quality of life look like right now? Is this person in distress? Is this person comfortable? All right, they're comfortable. They're not comfortable. Why are they not comfortable? Is it a stomach issue? That's not uncommon. Is it a spasticity issue? That's not uncommon. Is it a headache? Who knows? Because they're not telling you. So part of the deal is you got to kind of figure out what is going on. And then as a parent, you've got a pretty good idea of what makes your kid tick, you know? You've got a good idea. You are the one who has the PhD in neurology specific to your child, right? Because you've done the things. You've been to the physicians. You know what a good physician feels like going to versus a poorer physician. You know the people who are going to try, the people who are going to go the extra mile for your child, and you know the people who aren't. You know those, right? And so you make choices. You make choices with your dollars. You make choices with your time. And you make choices that also indicate to your child where your confidences lie, and their confidence parallels your confidence. We're all emotional sponges the first 3 years of our lives. And for longer than that for those kids who don't speak right away. And that means that we're particularly adept at picking up the emotional charge of the people around us. If that's sad, grief, all that stuff, that may not be the most beneficial for that child coming back. If it's happy, if it's inspiring, then that's what we would like to help them accomplish, is what does their full potential look like? And everybody's full potential is a little different than everybody else's, right? And no two children are the same in their injury, even if they have the exact same injury, even if they're underwater for the same amount of time, even if they're dropped from the same distance, even though all other factors could be exactly the same, those two separate individuals are going to be different in the way they manifest that. And we have a number of patients who are twins who had similar injuries, and one does really well, and then the other one doesn't do as well. So then you got to come up with other strategies. The last thing you want to do is keep pounding away at the same old strategy that might have worked on the other child, as if it's going to someday work on this new child. Other child is not going to. So part of our version of bliss is also understanding that Modern medicine, as it's practiced in the United States, is an endeavor trying to standardize therapies, trying to make it so that there are one sizes that fit all. Why? There's a huge economic advantage, right? If you make the product that every single person in the country uses, and let's say you make $1 on it, you just made $300 million. That's the drive, right? Is the drive in the medical industry for coming up with new ideas, is that driven by the need, or is that driven by economics? Does Big Pharma make choices in your best interest as an individual member of this society? Hell no. They don't. You know why? Because the stockholders don't want that. The stockholders want to know that I paid this much for this stock, and I want to know that in 10 years, this is going to be worth this much. I used to be a chemist for Procter Gamble. We literally put it on the wall. You work for the stockholders. Remember, you're a stockholder. We are coming up literally verbatim. We aren't coming up with solutions. We're coming up with management processes because we are creating a 30-year relationship with our consumer. That's economically viable. So when you start taking that blood pressure medication, is there an exit strategy? No. You're broken. You're going to be on this the rest of your life. Sorry about that. Really? Listen, I can get a reasonably healthy person to a place where they can run a marathon in a couple of months. That's pretty amazing, if you ask me. Humans are incredibly adaptable creatures. We can adapt to things that boggle our minds. Why are we selling ourselves short? Because there's a profit motive to sell ourselves short. If you're broken forever, then you're going to always be in this drug. Now we don't have to worry about it anymore. My final project for Procter & Gamble was to make a product that would reduce people's cholesterol by resensitizing their LDL receptors in their liver, so that your liver realized, hey, you made way too much cholesterol, so stop making that much cholesterol. No side effects except you have really beautiful bowel movements in the morning. And you take it for 6 weeks, and now you're sensitized, and you may not have to take it again for a year, depending on what your lifestyle looks like. I thought it was brilliant. Procter & Gamble says, first of all, we own this and you don't, so don't take it anywhere. Second of all, because you sign a little non-disclosure that says that, if you even dream up something, Procter & Gamble wants to own it. The model is broken. They shelved the project. I said, this was a good idea. We went through phase 1 and phase 2 clinical trials with the FDA, and then they shelved it. And I was disappointed. And I called my boss. His name was Andy. He's in Cincinnati. That's where Procter & Gamble's headquarters is. And I said, hey, so this happened. What now? He says, there is no what now. You go to a different project. But what about this thing? He says, we shelve it. I said, is there a lot of things that are shelved like that? He says, oh yeah. He sends me a whole printout of like the last 5 years of stuff that P&G has shelved. Make no mistake. The people who make the medications are there for the money. This is not a humanitarian effort. GlaxoSmithKline and Pfizer don't care who you are, and they don't care, right? Because they're making some money. Nestle dominates your baby formula. In order for me, years ago, after teaching nutritional biochemistry at the medical school for 6 years, we made a customizable formula for people with cystic fibrosis, which allowed us to vary the protein source, the carbohydrate source, and the fat source so that we got the right nutrition. But for those kids who had sensitivities to some of those things, we could vary it. Well, in order for my patient who was being admitted to Phoenix Children's Hospital for a procedure, in order for them to administer this formula that she'd been on and doing well with, I had to take the Nestle's registered dietitian program. It took me half of a Saturday. It was pretty stupid, but the fact that I had to jump through that hoop was sort of an indication of who pulls those strings. All of that is not meant to dissuade you from using medications or the appropriate therapy, but it is to dissuade you from talking to people who are automatic. Some people talk in scripts. You know them. A lot of medical professionals speak in scripts. There's no meaning in it. It's rhetoric. You're in a political world. What is rhetoric? Lies. Lies. Out of context information that may or may not pertain to your particular situation. So it's incumbent on us as children, as parents of our children, to be as much of an expert as we can in the processes involving their particular care. Because the final level of accountability is, who are you taking care of and for how long, and what does that require of you? And what does that require of them in order to get to a better quality of life? So with that, I say thank you so much for your kind attention and welcome to this conference. Thank you.